Extract 1. Questions 1 to 12. You hear a gastroenterologist talking to a patient called Andrew Taylor. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Taylor. Now, you've been referred to me because it's possible that you're suffering from irritable bowel syndrome or a related condition?
Yes, that's right.
Okay, could you start by giving me some background?
This has been going on for many years. After meals, I've always tended to get heartburn, but I found that pretty easy to deal with by taking antacids from the pharmacy. But a year ago, things suddenly got worse, and there were other problems I started to notice. The symptoms vary a lot, and they can be quite hard to describe exactly, but the main problem is bloating.
I see.
I need to tell you about some other things related to my stomach.
Mm-hmm.
Although this isn't something that happens every day, I've been suffering from constipation in the last month. In the past, I've had the opposite problem and would rush to the toilet several times a day. I just never know how I'm going to feel from one day to the next. It's the way the symptoms are so unpredictable that I hate. It's hard to plan my life.
Were there any other symptoms unrelated to your stomach and bowel?
Well, I have a skin condition that can flare up, and I know this could be related to irritable bowel syndrome. And the odd thing is that I often have migraines more or less at the same time as the stomach discomfort, and these can go on for days. It's strange, and I didn't at first think it was anything to do with my stomach problems.
Have you noticed anything that can intensify the symptoms in any way?
Well, I have a very demanding job as an accountant. I don't know whether this has a bearing on anything, but there's a chance I might lose my job in a reorganization of my department, so that's obviously something that's making me anxious. I don't know what's going to happen.
What's the worst effect the condition has on you?
The problem isn't just that it's nearly always on my mind, unless there's some pretty big distraction, but also that it's so draining. What I mean is, I often feel that I've got no energy at all. I just want to sit around and do nothing when I get home from work, to be honest. I go to bed tired, but I'm frustrated because I have insomnia much more than I ever did before. I wouldn't say I've been suffering from depression, but a condition like this can make you feel rather down.
Right. And I understand that you've investigated the possibility that your diet's responsible for your condition. Can you tell me about this?
I was told by a nutritionist I saw that people with irritable bowel syndrome often don't eat enough fiber. In my case, I don't feel that's an issue. I've followed the nutritionist's advice about taking more fluids during the day, especially water, and accept that in the past maybe I didn't do that enough. It's hard to say whether that's made a difference, but possibly it's caused a slight improvement. I'd read that dairy products can make things worse, so I tried cutting them out, but I wasn't convinced it made any difference. I've cut back on caffeine, though not much, actually. I also paid for extensive food allergy tests, but they didn't show anything major, so that's not an area my doctor thought was worth investigating further.
What medications have you tried?
Well, I took something called an antispasmodic, which my GP says helps to relax the muscular contractions which move food through the gut, but to be honest, I don't think it made much difference in my case.
Have you taken anything else?
Well, I've been given antidepressants, and I'm giving them a go. I wasn't sure I completely understood the reasons.
Okay, well, a drug like that targets the signals being sent to and from the nerves in the digestive system. It has a calming effect on the muscles there. Do you find that this drug was effective?
Yes, I'd say it was on the whole. Um,
You hear a GP talking to a patient called Mrs. Wright. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Afternoon, Mrs. Wright. I'm Dr. Kildare. Now, unfortunately, your usual GP is away today, so I'm going to help you if that's okay.
That's fine. Thank you for seeing me.
Okay, so I've got some notes, but it'd be helpful if you could tell me in your own words about the problems you've been having.
Well, Dr. Grimmett asked me to come back and check in about my foot. I've had gout, you see.
Okay, so just remind me, what happened with your gout?
Well, the first time was late last year, about 2 or 3 months ago. Dr. Grimmett had to treat me at home. It was pretty bad. I could hardly walk. We used steroids in the end to get a hold of it. I had the prednisone tablets, 30 milligrams for 5 days.
Right.
All the blood tests showed that I had the tendency to gout from crystals, so Dr. Grimmett gave me the allopurinol, trying to calm that down longer term. The doctor said to contact the clinic if it got worse, or come back around now just to check in.
Right. So we haven't seen you. Is that a good sign?
Well, I had, it was a good job I had the repeat prescription for steroids, because just after Christmas I had a bit of a flare-up again. I suppose I was eating a bit too much rich food and probably had more to drink than normal, but I have been watching it a bit. The doctor recommended I drink more water. He said 8 glasses, a couple of litres. And I've been trying, but it's a lot, you know, and I'm busy, so I don't think I drink more than 6 glasses through the day. But it's definitely more than before.
Right. Well, that's really good to hear. Water can definitely help, so it's great that you're keeping that up. Sorry, do you mind just describing where the swelling was when you had it?
Yeah, sure. Well, both times it started down the side, kind of at the base of the second toe on my left foot, there. And then the whole foot swelled up across my smaller toes to the outside of my foot.
Ah, I see.
And both times I started getting a lot of pain, and it was all kind of spreading down from that area, and it went across the toes and started swelling up quite badly, really hot and inflamed. But it never goes to the big toe. So the second time, it never swelled up quite as bad as it did before, but I think I caught it in time when I went and got the steroid tablets from the chemist.
Ah, good. So how long did it take to settle down once you started the tablets?
It was a lot better than last time. I went straight back down within a week, so it was a lot better.
Right, and when it settled down completely, is it back to normal?
No, it's never been back to normal. I still have pain on that second toe where it always was right from the start, and I've still got it now.
Right, and how are you getting on with the allopurinol?
Yes, it seems to be better. I don't have any problems with it. I'm taking them okay, but like I say, that second toe is still giving me a little bit of a problem.
I see.
At the time, the doctor actually wondered if it might be a stress fracture, but I had a foot x-ray and that was clear. But I just think it's a bit unusual that it's still sore, and at the same time, everything points to gout, and the blood test confirmed that was the most likely thing. But that toe, it isn't the usual joint, as you know, for gout. It's usually the big joint, isn't it?
Yes, that's right. The big toe is typical.
But when I had the flare-up, the steroids really helped quite quickly. I stopped taking painkillers after 2 days at most. I feel like it's less severe and we've got a hold of it better. So I guess that means the allopurinol is helping, right?
Yes, I think so. So I'm still quite keen to carry on with that tag.
Part B, questions 25 to 30. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. Now look at question 25. You hear a nurse reporting to a medical team about a patient. Now read the question.
We have one geriatric patient, Mr. Drake, in room 242. He's had 2 strokes in the past, and there's some cognitive impairment. The reason he was admitted from his nursing home yesterday was essentially that he's been refusing food for 3 days. But there are definitely signs of depression. Last night, the duty nurse reported that he was saying, "I want to die, I want to die," though he didn't say this to me personally. Apparently, his wife's in another nursing home. They have no contact and she's not been able to visit him. So we're going to try to figure out how to get them together, because that'll give him something to look forward to. In the meantime, the plan is to get him up. We'll start with the cardiac chair until physiotherapy can see him.
Question 26. You hear a hospital nurse talking to a patient about oxygen therapy. Now read the question.
Mr. Anand, here's the oxygen mask, which we agreed would be a good idea while you're having breathing problems.
Oh, thanks.
Now, it's really easy to operate. Have you used one before?
Yeah, at home last year for a fortnight. I think I remember what to do.
Good. So you're aware of the effect on your mouth?
I'll keep drinking a little and often, because otherwise the oxygen can dry it out, can't it?
That's right. You've got to keep hydrated, so do shout out if your water jug needs refilling. Do you have any other concerns?
Well, last time the skin here, behind my ears, got quite painful and raw because of the elastic straps tight against it.
Well, if you use these little pads and loosen the straps, it'll stop that happening.
Great.
Question 27. You hear a surgeon briefing her team about a patient they will operate on later in the day. Now read the question.
And the next on today's list is Freddie, who's a cloacal extrophy with a cross-fused ectopic kidney. He has a history of respiratory infections too, and there's a high risk of him getting another one following the procedure, so he'll need to be in the intensive care unit. We obviously can't start until we hear there's a place for him there, but they're calling us shortly and they sounded pretty positive this morning. This is today's main case, and I'd like to get started around midday so we can spend the whole afternoon focused on this.
Question 28. You hear two hospital nurses talking about a patient's medication. Now read the question.
Now, Mrs. Thompson here needs IV administration of her antibiotics.
Okay, I was a bit worried about her swallowing reflex actually. She's hardly touched her food since she came in. But she's been assessed by the therapist who said there wasn't a problem.
She's been unable to keep anything down since yesterday morning anyhow, so there's no point trying to give her the tablets.
I see her operation's set for Friday morning, so she won't be able to eat in any case in another 72 hours. But that still gives us a window for the antibiotics. We'd still better use IV to be on the safe side.
No problem. I'll set up the drips straight away.
Question 29. You hear a pharmacist talking to a customer about head lice in children. Now read the question. Hello. Can I help you?
Yes. There's nits going around my son's school. I need something that'll stop him getting them, because they spread like wildfire, don't they?
Has he got any symptoms? Has he been itchy or had a rash?
I'm not saying he's got nits, it's more that I want to make sure he doesn't get them.
I understand that, but unless your son's been confirmed as having head lice, it isn't advisable to use medication.
I was told there was a lotion you could buy over the counter. I mean, if the nits jump from one kid's hair to another, it's only a matter of time. What's the point in waiting?
Well, first of all, they don't jump. To get head lice, your son needs to be in very close contact with another child who has them. Even then, it's by no means a foregone conclusion. Also, if they're detected early enough, you might get rid of them by combing alone. If that didn't work, well, then we'd recommend a lotion. Question 30. You hear an ophthalmic consultant giving feedback to a trainee who has just carried out an eye examination. Now read the question.
So, were you happy with the examination?
I think it was okay overall, but it was hard carrying out the procedures while having to deal with the patient's questions at the same time.
Yes, that can be hard. But there were lots of good things. Reassuring the patient when necessary certainly helped the process. The patient seemed rather confused sometimes about what you wanted him to do, though. That's something to work on. Think about effective ways of communicating what's required. You described in full the reasons for the various procedures, and adapting your language style to this particular patient did seem to relax him. That sort of approach puts patients at ease.
Right, thanks.
Part C. In this part of the test, you will hear two different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer, A, B, or C, which fit best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the doctor's lecture on coronary artery disease. You have 90 seconds to read the questions 31 to 36. Coronary artery disease, also called atherosclerotic heart disease, is caused by the accumulation of atheromatous plaques within the walls of the coronary arteries that supply oxygen and nutrients to the myocardium. The condition is also called coronary heart disease at times. Although coronary artery disease is the most common cause of coronary heart disease, it is not the only cause. Coronary artery disease is the primary cause of death worldwide. While the signs and symptoms of coronary artery disease are seen only during the advanced stage of the disease, most patients with coronary artery disease show no symptom or sign of the disease for decades, as the disease keeps advancing before the first onset of symptoms of an acute myocardial infarction, a sudden heart attack, finally arises. After decades of development, some of these atheromatous plaques may rupture, and along with the activation of the blood clotting system, begins to control the blood flow to the myocardium, causing sudden death. This disease is also the most common reason of death over 20 years of age. According to prevailing trends in the US, half of healthy 40-year-old males will develop coronary artery disease in the future, and 1 in 3 healthy women of 40 years. The Guinness Book of Records show that Northern Ireland is the country with the most occurrences of coronary artery disease. Contrarily, the Maasai of Africa have almost no coronary artery disease. As the severity of coronary artery disease develops, there may be almost complete obstruction of the lumen of the coronary artery, totally restricting the flow of oxygen-carrying blood to the myocardium. Patients with advanced coronary artery disease typically have suffered from single or multiple myocardial infarctions and may have symptoms and signs of chronic coronary ischemia, including symptoms of flash pulmonary edema and angina at rest. A careful distinction should be made between myocardial infarction and myocardial ischemia. Ischemia means the amount of blood supplied to the tissue is insufficient to meet with the needs of the tissue. When the myocardium becomes ischemic, it does not perform optimally. When a maximum portion of the myocardium becomes ischemic, there can be difficulties in relaxation and contraction of the myocardium. Myocardial ischemia can be reversed if the blood supply to the tissue is improved. Infarction means the tissue has undergone irreversible death due to the lack of adequate oxygen-rich blood. A patient may develop a rupture of an atheromatous plaque at any stage of coronary artery disease. The acute rupture of the plaque may result in acute myocardial infarction.
Now look at extract 2. Questions from 37 to 42. You hear a doctor briefing his juniors about blood transfusion. You have 90 seconds to read questions from 37 to 42. Extracting blood or blood components products from one individual and inserting them into the circulatory system of another individual is known as blood transfusion. Therefore, the blood transfusion can also be considered a form of organ transplant. Generally, it is performed as a treatment for different medical conditions, such as massive blood loss due to surgery, trauma, shock, and other conditions in which the body tissues are not oxygenated adequately, where carbon dioxide or other toxic materials are not effectively removed, and where the red cell producing mechanism fails. Great care should be exercised during a blood transfusion to make sure that the recipient's immune system is compatible with the transfused blood, and also that the donor's immune system is compatible with the recipient's immune system. Moreover, blood type classifications A, B, AB, and O, and the rhesus factor classification, positive or negative, should be verified. Nowadays, a number of tissue type factors are also considered to determine histocompatibility. These tissue type factors become increasingly crucial in patients who receive many blood transfusions, as their bodies have to develop increasing resistance to the transfused blood. Depending on the needs of the community, at the time only parts of the blood are taken for transfusion. Blood is composed of red blood cells, platelets, and plasma. The platelets and plasma can be donated separately in a process called apheresis. In this process, blood is separated into components after being extracted from the donor. For instance, albumin protein is transfused for treating burns, and platelets used for treating hemophilia, cryoprecipitate, and immunoglobulin antibodies are transfused for treating immunological disorders. There will not be transfusion-related risk factors for the blood donor while transfusing the whole blood, besides the minute chance of infection or injury to the site. However, this is a certain risk to the donor when he donates plasma and has red blood cells reinfused. However, this risk is preventable by following appropriate sterilization procedures. Significantly, it has caused severe public health hazards in China, where they were often unregulated. The plasma collection centers of the U.S. are the best-known examples of safe apheresis donation, which is maintained by pharmaceutical companies, involving paid donors up to twice a week. Interestingly, veterinarians occasionally perform blood transfusions to animals. Different species require different levels of testing to ensure a compatible match. Cattle have 11 blood types. Cats have 3 blood types. Dogs have 12 types of blood. Pigs have 16 types, and horses have 34 types of blood. The experimental and very rare practice of interspecies blood transfusions is known as a form of xenograft.